Well, thanks for coming back. We're examining this Journal of the American Medical Association paper of the 5th of February. And today is Monday, the 10th of February, 2020. So we've just looked at how this virus is adsorbed into cells causing infection. Now, carrying on, we want to learn this paper, this JAMA paper, reviews the spillover mechanism from animals into humans. Now, SARS went from bats to civet cats. Now, in these videos, I'm going to try and not get too emotional. We want to deal with this rationally. So I'm going to mention it now, then I'm not going to mention it after this. But the idea that you would take wild animals, cage them, abuse them, sell them for food and eat them is just outrageous. We stopped being hunter-gatherers 10,000 years ago. Agriculture's been going on for 8, 9, 10,000 years. We don't need to do this. We really don't need to do this. But that's what happened, right? So I've made that point. So objectively, the virus went from bats to civet cats to humans. Probably one of the live animals scratched someone or salivated on them, or probably fecal contamination could have been another method. So fecal contamination from the animal, from the gut of the animal when it was butchered, would get into the meat, and if the meat's not properly cooked, that would transmit the virus into the human. Or from butchering the animal again, contact with animal feces from gut contents, and into the mouth or mucous membranes. That's probably how it happened. Well, I think we know that now from genetics. Bats to civet cats to humans. That was with the SARS, with the severe acute respiratory syndrome. Now, MERS comes from camels. Now, I think here the main mechanisms of spread are camel feces, camel urine, camel milk, and camel meat, because camels are eaten. They're probably the main ways of spread. So if the milk was boiled or pasteurised even, I think, or certainly if the meat was cooked properly, that will kill the virus. But then, of course, there's fecal contamination from the animal, working with the animal, and again, poor hand hygiene. So these are sporadic cases. Now, when we get the sporadic cases, MERS, it's actually a very serious disease. There's a high mortality, but fortunately we don't get many. Now, unpeer-reviewed suggestions are that the current novel coronavirus comes from pangolins. Now, I haven't got any non-copyrighted pictures, but if you Google pangolins, they're the cutest creature. They're long-snouted, ant-eating mammals. And the tragedy for the pangolins is that they have what I can only call mythical properties in Chinese medicine. Now, I'm not knocking traditional medicine altogether. There's a lot of great traditional bone-setting methods in Chinese medicine, for example. There's a lot of great herbalism. Remember, 25% of our current formulary here in the UK today comes from plant-based products. Digoxin, atropine, morphine, aspirin. Many things come from plant-based originals. But the molecules that you get from plants are small molecules that can be absorbed into the human body, therefore can have some therapeutic effect. That's why plants can be poisonous, of course. But when we're talking about animals, animals are made, like you and me, of protein and fat. So if you eat a pangolin, unthinkable, but if you were to eat a pangolin, then the protein in that would be digested to amino acids just as surely as you've eaten a sausage or a piece of cheese. It's broken down into the 20 constituent amino acids. So the idea that these animal products, whatever it is, rhino horn or snake gallbladder and all this stuff, it's just pre-scientific mumbo jumbo, because it's all fully digested when it goes into you, but by the pepsin and the hydrochloric acid in your stomach, or the hydrochloric acid that facilitates the action of pepsin. It's all digested, so it's not going to have any therapeutic effect. So really what we need to do, I mean, and of course there's brilliant academia in China, so what needs to happen all around the world is we need to take the best and the good bits out of these traditional healing therapies and disregard that which is nonsense. And eating animals because the proteins are digested is nonsense. But a lot of people don't believe that, so there we are. So it may well be that this has come via pangolins. Not peer-reviewed yet, so I can't say definitely. And actually that bit, I don't think that bit was in the... I don't want to malign JAMA of the 5th of February 2020. I don't think the bit about pangolins was in their article. In fact, I'm pretty sure it wasn't. So that's probably a bit I've added when I was thinking about this. So. Right, now, JAMA state here that the majority of secondary cases, that secondary spread, that is not people that have got it from the primary animal source, but people that have got it as a secondary spread, comes from symptomatic individuals. That's what they're saying. And this does kind of make sense if we look at our graph, because as we've noticed, the viral load goes up over time and is high during this red bit when the person is sick. If you want to know in detail what this is about, watch previous videos. It's all on there. It's called evolution of the disease. So that's what they're saying. However, later on today, there's some other information I want to look at that shows that there are super spreaders that have been spreading this when they are asymptomatic. So, for example, a week or so ago, we talked about a case in Germany of a Chinese businesswoman who came across from China, from Shanghai, I think it was, and infected a German businessman just through normal social interaction, probably involving a handshake. So he was infected from her, and at the time, the literature did report that she was asymptomatic and got sick on the plane on the way back. It turns out that wasn't true. It turns out she was somewhat symptomatic when she was on the business trip and became sicker on the plane on the way home. But there's other reports of people that do appear to be spreading the virus when they are quite well. So, but I'm just reporting what's in the peer-reviewed literature. 5th of February, JAMA is saying that the majority of secondary cases come from symptomatic individuals. But it remains my belief, looking at the totality of the data, that asymptomatic people certainly can, well, I believe, certainly can spread the virus. That would be spreading it when the viral load here is increased just before they get ill. So the probability of someone passing the disease on would be highest just before they get ill and just after they get ill, in my view. But the evidence on that is not completely clear yet. But when JAMA says that the majority of secondary cases come from symptomatic individuals, clearly they're leaving the door open that a minority, which could be 30%, we don't know, a minority of infections come from asymptomatic individuals. Now, JAMA agree that the clinical syndrome is non-specific. Now, what this means is a non-specific illness. It means, I just don't feel well. I just don't feel well. There's nothing wrong with any particular part of my body, just don't feel well. That's kind of non-specific. It hasn't yet localized. There's no localization. So a lot of people just feel ill. But the clinical syndrome is characterized by, and this is somewhat contradictory because a cough and shortness of breath are localizing features. But basically it's saying people don't feel well generally, but usually there's a fever and a dry cough. So we've noticed that the original presenting features are fever, dry cough, and tiredness are typical presenting features, this undue fatigue. But we did notice yesterday that 10% of cases did present in one study as gastrointestinal disease, nausea and diarrhea, and vomiting, I believe. But most present with fever, dry cough, and malaise, feeling ill, and this undue fatigue, this tiredness. And 33% have shortness of breath. Now, it's still quite a little bit unclear to me the degree to which the shortness of breath symptoms are related to the development of pneumonia. it looks like in the early stages people can be short of breath who don't have pneumonia. So that's kind of good, but it just makes it a little harder to differentiate with the diagnosis if there's someone short of breath. Of course, what it means is we need to do a chest x-ray. That's how you diagnose pneumonia. Myalgia, headache, sore throat, diarrhea are other possible presenting features. Now, the median age, remember the median's the one in the middle, isn't it? So median age is between 49 and 56, depending on the study you look at. So it's older cases. And as of the 5th of February 2020, JAMA is saying that cases in children have been rare. Having said that, there is a case in an English child who picked it up in France who was sharing a chalet with this super spreader chap. So, but my job's to report the literature. JAMA, the 5th of February, cases in children have been rare. I hope that's true. I mean, I just hate seeing sick children. JAMA is saying most cases appear mild, which is good. Most cases appear mild. And we did say this at the start of an epidemic, that the death rate can seem higher than it actually is, because you're comparing the death rate to the number of cases. But at the start of an epidemic, the number of cases that actually exist can be much higher than the number of cases that are reported, because people with mild illness might not report for diagnosis. So that could be a glimmer of encouragement here. All patients admitted to hospital have had pneumonia, apparently, lung infiltrates. Now, we've looked at this before, that the alveoli fill up with fluid, or the small bronchial passages fill up with fluid. And basically that means that instead of being full of fresh air, they're full of fluid. So the lungs appear denser than air. So a substance denser than air is in the lungs. That's what infiltrate means. So the lungs are clogging up. It's a pneumonia type feature. So that's the reason for admission to hospital. Now, of the people that are admitted to hospital, and we think that's about 17% at the moment, of the people admitted to hospital, about a third of these patients, so we think about 17% are admitted to hospital. Of the 17% that are admitted to hospital, about a third of the 17%, so that's, I don't know, it's 5.5% or something, just under 6%, about 6% of all cases. So about a third of the patients that are admitted to hospital subsequently develop acute respiratory distress syndrome, and this is caused by the filling up of the small airways and the alveoli with fluid. And they require either quite a lot of supplementary oxygen or other airway support. And this, of course, is the problem if there's a lot of cases. Even if only 70% of them are getting quite sick, even if 17% are severe, but if a third of those need more sophisticated care and we have a few thousand cases at once, that could be a problem. Could be a problem. Right, comorbidity is a factor in how likely it is that someone develops severe acute respiratory distress syndrome. That's what this paper is saying. And the comorbidities they pointed to were diabetes or hypertension. Now, we know there's evidence or correlation evidence from previous studies that hypertension is a risk factor. Now, interestingly, that might be something to do with the ACE that we talked about before. If you've watched the previous videos, we talked about this ACE receptor, which is involved in blood pressure control in fairly complicated ways. But that's just me speculating and thinking out loud. But we do know that hypertensive people are probably more likely to get this based on a correlation study. Now, the JAMA article says diabetes, so if they say diabetes, we have to accept diabetes as a risk factor. What I can tell you is that in diabetes you have raised levels of blood sugar levels, and raised levels of sugar in the blood mean you get raised levels of sugar in the tissue fluids, and that makes it harder for the immune cells to move through the tissue fluids. So generally speaking, we don't know whether it's true of coronavirus, but novel coronavirus, but generally speaking, if you're diabetic and you can bring your sugars down to normal range, then that's going to improve your immune function. So immunity is worst when people with diabetes are hyperglycemic, when their blood sugars are high. So good regulation with insulin or oral hypoglycemic medication combined with diet and combined with exercise would all be a very good idea. And it's likely, from what we understand, that that would reduce the probability of severe disease developing in people with diabetes. What I don't know, I don't think anyone knows this, is how well the hypertension is controlled, if that's a factor in the likelihood of developing ARDS. Because with hypertension, normally, as long as we can control the hypertension with medication, then these patients do very well. They don't get the long-term complications as long as the blood pressure is controlled. But whether that's the case with this particular infection or not, I simply don't know, and I'm not sure anyone knows yet. Now, JAMA, 5th of February 2020, said infected patients should wear a face mask when other people are in their company. So putting a face mask on the patient is actually the most important bit. So these surgical masks that you see people wearing, they're designed to keep bugs in. So when you've got your face over a wound, or you're operating or something, or you're working in theatres, then you don't want to infect the person with your bugs. So the masks are designed to keep infection in. So infected patients should wear a mask. So if the patient was in isolation, ideally they would be wearing a mask. Certainly when people are in working with them, they should be wearing a mask. And JAMA tells us that staff should wear N95 respirators, which makes perfect sense, to protect themselves. And of course, this is as well as, ideally gowns and gloves. Then the gloves can be discarded and the hands washed. But if not, if we're dealing with these people at home, then meticulous hand hygiene is absolutely imperative. If you learn nothing else from these videos, remember that you need to keep washing your hands, because the virus, we believe, gets from infected surfaces into your mucous membranes. The main reason for wearing a mask yourself for protection is to remind yourself not to touch your face. I shouldn't laugh, it's not funny at all. JAMA, the 5th of February 2020. In fact, it's tragic, I do apologise. Just laughing at the irony, really. JAMA tells us that what interventions will ultimately control this outbreak is unclear. So it's reviewed some of the issues that we've looked at, you and me, over the past almost 2 weeks now, and most of them have been confirmed, which is quite reassuring. Few things that we're not quite in full agreement on, but they're going to transpire fairly soon. But it's nice to get some of our thinking confirmed by the Journal of the American Medical Association.